Friends, welcome back to my new video. And I have come today with a very short video where I thought I will not bore you with a long video, and let us make it short. And I have come this time with the topic of ACS, that is acute coronary syndrome and cardiac arrhythmias, and with a kind of a perspective of an intensivist for the management of ACS and cardiac arrhythmias. And we will divide it into couple of short videos, the same topic, so that you will not get bored. And we will make a few more videos on the same topic. So this was a particular topic which I delivered during the 18th annual intensive care PG refresher course, which was organized by ISCCM, that is Indian Society of Critical Care Medicine, Pune branch, in the month of March 2023. So here we are post Diwali. I'm sure everyone would have enjoyed their Diwali with your family, friends, everyone coming together, and you must have got rejuvenated. And of course, now everyone would be back to your work. And here we are again with a new video. So, without further ado, let us start with the topic. So, as far as ACS is concerned, it's a very interesting history, and we learn by our history. Let us go back to 1958, where coronary angiography was developed by Sones. And then, if you see the famous terminology, that is CCU, this particular concept of coronary care unit was developed by Dr. Julian in 1961. So it is not a new thing, and it is a reasonably old concept of CCU, which came in vogue in way back in 1961. And then, of course, we had first beta blockers, which was developed in 1962. Interestingly, even before angioplasty, it was the description of CABG, that is coronary artery bypass graft, which was devised first in 1969. So it was quite some time back. And then you have this photo here, and in the year 1979, and this is Professor Grunzig, who kind of came out with the concept of coronary angioplasty. So it was kind of a revolution during that time, and this coronary angioplasty, which was developed in 1979, so it's almost, if you see, almost more than 40 years. So it is very interesting that we're talking about angioplasty, which is so old. So then you can see that somewhere in 1993, uh, I'm sorry. So in 1993, as you could see, the studies showed superiority of the primary PCI or PAMI as compared to fibrinolysis in acute MI. And then in 2002, there was a efficacy of drug-eluting stent, which was shown far superior than the bare metal stent. And from there, the drug-eluting stent started getting introduced, and then were extensively implanted in the appropriate patients. So it's a very interesting slide with a nice snapshot of the history, which is so very important, and you can get some insights as to the timelines related to the acute coronary syndrome and its treatment. So, coming to this mnemonic, which is a very interesting mnemonic, uh, with by the name of chest pains, and it actually is a mnemonic related to the evaluation and the diagnosis of chest pain. So just if you can see here, so C starts with this mnemonic starts with C, that is chest pain. Then H is for high sensitivity troponins, which is preferred. E is for early care. S is for share, to share the decision making. T is for testing, and then of course the routine testing, which is not routine in the low risk patients. P for the pathways, the clinical decision making pathways. A for accompanying, the woman may be more likely to present with accompanying symptoms. I is for identification of the patient, N for ruling out the non-cardiac chest pain causes, and S is structured. So it is a structured risk assessment which should be used. So in a nutshell, you can actually just remember chest pains, and it encompasses the majority of the evaluation and the diagnostic modalities for the chest pain, and we will discuss it in detail a bit in a short while from now. As far as the chest pain is concerned, which is ischemic in origin on the basis of the commonly described symptoms, which you can see from going from the red color to the green color as high probability of ischemic chest pain to the low probability. So, as you could clearly see here, a pain which is central with a pressure sensation or a squeezing sensation or a gripping sensation. So these are all words are very important because they points towards the probability of ischemic chest pain. There is heaviness in the chest, tightness in the chest, exertional or stress related pain, and a retrosternal pain. So all these are the very classical description of the chest pain. And then a lesser common or the lesser probability is left sided pain, with which is dull aching pain. The stabbing pain actually is in the middle of high and low probability, where, as you know, that there could be other causes of stabbing chest pain as well. One of them could be aortic dissection. Coming to the right side of this is right-sided chest pain with a tearing, ripping, or burning character. And then, of course, the extreme right, as you could see, which actually will say that the probability of the ischemic chest pain is less. And in this, there is a sharp, flitting, shifting, plurating, and a positional pain. So, each and every characteristic pain here which is mentioned is clinically important and relevant. So if someone comes to you with a left sided pleuritic chest pain and is crying in front of you, most likely it is a non ischemic chest pain. Whereas someone who comes with you in your clinic with a squeezing or a gripping or a heaviness in the chest, or maybe in your ER also, you are compelled to think that this patient can have ischemia. So, this is a very important slide according to me. So, of course, these are few of the signs and symptoms, and the classical chest pain with heavy sweating, extreme anxiety. There's sometimes the patient can faint with some sensation of indigestion and shortness of breath. So when the chest pain patient comes in ER, or you are evaluating a chest pain patient, you need to be aware of differential diagnosis of that particular chest pain. So as we have discussed, the cardiac pain can be related to angina. It can be, of course, a pain of acute coronary syndrome. As I said, aortic dissection, when they can have a very sharp and shooting pain, or it can be a pericarditis pain. So, as far as cardiac conditions are concerned, these are very common conditions which a clinician or an intensivist attending a patient of chest pain should remember. Followed by the respiratory causes, as we know, pulmonary embolism, which should not be forgotten, pneumothorax in a proper clinical context, and of course, pneumonia can also present as a chest pain. So, these are few of the conditions related to the respiratory system, following which we should actually have gastrointestinal causes which can also present as chest pain. Amongst them are esophagitis, esophageal spasm, or peptic ulcer disease. And of course, there are other causes like costochondritis. There can be a rib fractures which can go unnoticed, or a herpes zoster. So it's very crucial and important for you to have a look of the patient in a detail, where the patient can be examined in detail to look for any herpes zoster lesions. And of course, the last can be depression or anxiety. So don't put the patient, or don't label the patient as hypnotic patient or hysterical patient if he comes to you with a chest pain. Obviously, it is a diagnosis of exclusion, and you need to actually rule out these causes first before you label any patient as a hysterical patient. And this is probably this is my last slide today, and I'm ending it after this slide. As I said, we'll make short video so that you can remember what we discussed, and obviously you will not get bored. So this is the risk of the major CAD event. So if the patient is asymptomatic or in a low risk group, probably you may not go ahead and do any testing as such. But to be very frank with you, the patient himself or herself will come with an ECG to you, and they will say that because he or she had this kind of feeling, they went to the hospital, nearby hospital, insisted upon them to have an ECG, and comes to you with ECG, which probably would be normal. Coming to the intermediate risk, of course, you need to actually take care of this chest pains mnemonic, which we just now discussed. And of course, the ECG will be there. So you can actually have a fair idea whether this patient can have a likely possibility of CAD or ACS. And here we are, when you are going up in the pyramid to the high risk of ACS or a frank ACS. Of course, the invasive angiography is the mainstay and the gold standard as far as the diagnosis of ACS is concerned. Mind you, please don't think of CT coronary if your suspicion is high suspicion. So if there is a high clinical suspicion, please go ahead and do a invasive coronary angiography, which is a gold standard, rather than going with a CT chest, which is not a gold standard. So here I will stop, my friends. I'm sure you will actually love to listen to this short video, and of course have some knowledge or increase in your existing knowledge as far as the risk assessment, the differential diagnosis, and the historical perspective of acute coronary syndrome. In the next coming videos, we will discuss obviously upon the therapeutic aspects, the different modalities, the pharmacological therapies, the pharmaco-invasive therapies, and so on and so forth. And of course, we will have the discussion on arrhythmia. So that's all for now. Take care. Bye bye.